inhibitors inhibit ACE, which is part of that renin-angiotensin-aldosterone system. And if you haven't visited that in forever, there's a short little video in the classroom PowerPoint that you can watch if you want to. I'm not going to test you on AMP. I'm not going to test you on AMP. So don't waste your time a lot on this, all right? And that's why I'm not going to waste mine too much on it. But ACE inhibitors inhibit the conversion of that process to where it blocks a lot of vasoconstriction. So with that being said, ACE inhibitors also drop blood pressure. Both ACE inhibitors and beta blockers can cause orthostatic hypotension. Do y'all remember that? Mm-hmm. Most of your blood pressure medicines cause that. So when you're at the hospital and you have patients taking these meds, especially if it's the first time, you be careful letting them get up out of bed because they're going to need you and assistive devices to stay safe. Does that make sense? Mm-hmm. Okay, with Creels, what are some weird things about the ACE inhibitors that you recall? Yes, they can that's perfect. One of the most common side effects of ACE inhibitors is a nagging cough, and it's one of the most common reasons that they will have to take the patient off an ACE inhibitor, and they'll put them on an ARB instead. And the other thing about ACE inhibitors, a couple of other things. Monitor their potassium level, because when they're taking an ACE inhibitor, especially older people, their potassium levels will creep up. And so there are times when the doctor will take them off the ACE inhibitor because they're retaining too much potassium. Okay? One other thing that jumps in my mind about an ACE inhibitor is we cannot give it to women who are pregnant. And sometimes, even y'all shock me sometimes. I've had some of y'all walk up to me and say, I'm like 28 weeks gestation. I'm like, what? I didn't even know you were pregnant. And so, and the way people will tell you sometimes or not tell you, and that is a huge safety risk. If you go to the hospital and you are pregnant, you need to make sure everyone knows that. But not everyone knows to tell you that. So I've had patients before, for other reasons, they were in a car wreck or whatever, they were on orthopedics, and go in there and I'm kind of helping them do stuff, and I'm like, it's kind of round. You're not supposed to, in the southern world, ask a woman if she is pregnant. I'm impressed if you ask me. I'm like, oh, she must think I'm of that age. Yes. It won't offend me a bit. But most people are very offended, okay? And so, but as nurses, there are ways we can do that. And if someone prescribes a medicine, you got to make sure, if you're going to give an ACE inhibitor, they don't need to be pregnant. And that's with many medicines that can cause fetal, problems with the fetus. So make sure, as a nurse, that you're not scared to ask, especially if someone is of childbearing age, because I don't know where you're going to go to work. And the hospital has got it all in the database down pat, but if you've ever seen that database, it's this long, and so we are trying to skip through that sucker as fast as we can, and sometimes we skip over stuff that we shouldn't have, and we catch that. All right, so you understand what med categories you're responsible for, right? We'll hit a couple more of them as we go through our lecture. We have a lot of lecture, and so sometimes I don't want to miss it, so I'll kind of put a lot of it up front just to make sure. But we will be revisiting the rest of them. Because number one thing we do as a nurse is do what? Give meds. So look up here before I leave the syllabus. I went back to unit objective 1, and it talks about health history, physical assessment, vital signs, and lab. everybody in here, make sure you know how to do your cardiac assessment with your stethoscope, the 8 to man, all pigs eat too much, something about toilet paper myceps or whatever that is y'all do. Aortic position, pulmonic position where you put your stethoscope, herbs point, that's in the class PowerPoint as we're going to go through it. But if I don't stress it, a lot of times they'll say, oh, we covered that in level 1 and 2. We won't see that again. Oh, yes, you will. Yes, you will. So where do you listen for an apical heart rate?
At the base.
Right here.
Where?
The fifth interval.
You're so cute. She's like, right here. And she's right. And she's right. But it's the fifth intercostal space, mid-clavicular line. Here's your clavicle, right? Mid-clavicular line. And if you go down, count 5 ribs down, that's right under most women and men's breasts. Now, some of us women have to bring that thing back up where it's supposed to be. I don't have those, so it's funny when I act like I am moving it. But anyway, I don't have any problems with that. But some women, you are going to have some problems with that. And you have to move in, do it. That is what you're skilled to do. Don't act like you're doing something wrong. You know, you have got to do what you got to do. All right? So now, fifth intercostal space, left, on the left. I've been with many a student in clinical, and they're just as, I'm like, what you doing? And they're like, I'm counting the heart rate, and I just let them go. We walk out the door, I go, where is your heart? And I go, well, that's probably why it wasn't really easy to hear. I'm like, so it is funny. You just have a moment sometimes. So if you can hear it, good for you. And these people with these diseased hearts, sometimes it is easier to hear moving your stethoscope around because not always can you hear it really well when they're diseased and possibly shifted in the chest. Okay? Now, we had a little bit of a debate up here. Where is the base of the heart? It's at the top. Where is the apex of the heart? At the bottom. So where is the fifth intercostal space? The apex. It's at the apex. So don't be tricked because sometimes NCLEX will ask or ATI will ask, where would you find PMI, point of maximum impulse, or where would you do apical heart rate? And their options are going to be base or apex. You see what I'm saying? So make sure you understand the top of the heart is called the base. The bottom of the heart is called the apex. And the apex is where you're listening for an apical heart rate. Y'all got it? Do you need to know it?
Yep.
And the labs you're responsible for is on that lab PowerPoint. And I'm going to pull that up in just a minute. You should know what normal vital signs are. And let me clarify number 5. You see where it says cardiac stress test? You're going to be tested heavily on that. You're going to be tested heavily on an echocardiogram. And you'll also be responsible for an EKG related to how do you prepare a patient for an EKG. How do you teach a patient? How do you prepare a patient to have an echocardiogram? What do you tell them? How do you safely send a patient for a stress test? And do you see radionuclide imaging? That goes with a pharmacologic stress test. Okay? So don't stress out over that. We're going to talk about it. Under 6, it says telemetry monitor, EKG machine, pacemakers, and hemodynamic monitoring. You're responsible for EKG as far as what it is. It's electrical. We are monitoring electrical activity of someone's heart with an EKG, right? What do you tell them?
Lay back, don't breathe.
Don't breathe.
Be still.
That's good.
Be quiet.
Yes.
Be quiet.
Don't talk.
Okay, good. But y'all look. Lay down. Shut up. No,
No, don't say that.
I'm just teasing.
Don't touch the patient. or
Right,
the
don't
patient.
touch the patient. So teaching is very important before EKG. Because if the person starts talking, they're gonna mess up your EKG. If they start moving, they're gonna mess up your EKG. And so they need to be as still as possible while they're having their EKG. If they're extremely cold or shivering, it's gonna mess up your EKG. So make sure they're warm and comfortable.
They're breathing really
And
fast.
they're,
you
if
can't
they're, if you tell them, like we all tell them, you get this, now just take a slow deep breath. If they're anxious, you don't want them taking deep breaths while you're doing your EKG, because that's gonna mess it up too.
It's short, shallow breaths.
So you can let them breathe, but you just tell them to be as still as possible and try to do shallow breaths while this EKG is going on. Y'all with me? I didn't realize y'all didn't know that until I taught this a few times, but you wouldn't be expected to know it unless you experienced it, where it's part of where you work. So do y'all get that part? Y'all got the EKG part? Okay, so now, pacemakers. We're going to start talking about pacemakers, and you're going to find out that there are temporary pacemakers and permanent pacemakers. And I've got a whole PowerPoint to tell you about that. Hemodynamic monitoring is cardiac output, and you ready? I want you to start learning what MAP is, M-A-P, and it's not how you get somewhere.
That's the
Mean arterial pressure. MAP means mean arterial pressure, and it is the perfusion pressure seen by the major organs. And it's on the slide, we'll get to it. There's an equation. All I want you to know right now is MAP is part of a hemodynamic, and that is what your art line is going to give you. We'll learn that in level 4, but I need to introduce you to it right now. Mean arterial pressure is the perfusion pressure seen by your organs. How much perfusion your major organs are getting. I just want you to start getting that concept.
in 4. Do we like get to learn to manage heart lines?
You're going to learn a lot about stuff like that. That's what 4 is.
They're really confusing.
You don't have to know all that. You're a new nurse, entry-level nurse. Okay, get ready. The next thing I want to make sure you know as far as hemodynamics goes, write this down. C as in cat, V as in violin, P as in pizza, CVP is central venous pressure. The other name for that is right atrial pressure. And normal for you in the textbook, CVP or RAP, central venous pressure or right atrial pressure, they're the same thing. And normal is 1 to 8 in your textbook. So that is what you're responsible for, okay? All right, and interestingly enough, you're going to learn next semester that line, we have lines that we can drop in people, and we can get that number. And it will tell us what the right heart's, what CVP tells us, is the right heart's preload. So what's preload?
When they're coming into the heart.
Volume coming into the heart. Preload is volume coming into the heart.
So that tells us the right side preload.
Yes. Tells you the right heart's preload. That's what that number is telling you. And when you go into the unit, you can look up on the monitor, and if they have a pressure monitoring system hooked to their central line, it'll say CVP, and it'll give you a number. It is the coolest thing known to man. Because think about our heart failure patient that we're talking about. If we got a patient in right heart failure and we want to know how bad it is, guess what their number is going to be? About 30, What did I tell you normal is?
1 to 8.
And guess what? They're full of fluid. They are full of stretch coming into that right heart.
When the B and P tell you the same thing?
Different, but yes.
So if it's less than 1, that means there's just nothing there at all.
Girl is processing like a champ up front. Okay, so if CVP, also known as what? Y'all tell me.
Central venous pressure.
And what's the other word?
Right atrial.
That tells me the volume coming into the right side of the heart, okay? Because it's making it stretch, stretch, stretch. That number get bigger, 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 right? If it's going up. She said, and if it's like 0 or low, that means there ain't much coming in. Yes, they're dry. They're dry if the number's low. They're extremely wet if the number is high. And that's an easy, common sense way to look at it. So let's talk about a patient who might be in the ICU and we have a central line and we hook up a pressure monitoring system to it. What about the trauma patient who lost bunches of blood on the highway? What do you think their CVP is going to be? Low. So we start bolusing them with a bunch of fluid. We're going to watch this number to know if they're getting better. Does that make sense? Okay. So that's what that number is telling us. So you say to me, CVP is called central venous pressure, also known as right
Atrial pressure.
and it tells me
It's the right.
volume coming into the right side of the heart. Volume coming into the right side of the heart. The other way to say it is right heart preload, if you want to seem smart. It's okay. You don't have to. They don't think you're smart. They think you're showing off. You talk like that. I don't ever talk like I'm smart at the hospital because it turns people off.
Yeah.
It really does. And so it's funny because people don't know me are like, is she for real? You know, I'm like, for real. But anyway, I've learned a lot in 30 years. You don't act like you're smart. Trust me. Okay. They realize that. That will come. All right, so what hemodynamic monitoring did you just learn?
CVP.
And what else?
MAP.
And one more.
Cardiac output.
There's 3 things in cardiac output. Good job. That's what you're responsible for this semester, and you've already learned it, right? You're like killing me, Miss Cooper. You're just killing me. Okay. All right. Let's look at our content topics. Did you cover coronary artery disease in level 2?
Yes.
Do you remember all the risk factors?
No.
Modifiable, non-modifiable?
Yeah.
Okay, good. And we started the discussion on stable angina, which is predictable. What is angina? Chest pain caused by decreased oxygen to the heart muscle. Decreased oxygen to the heart muscle. Good deal. And if the coronary arteries become really occluded over time and they don't get any oxygen, what happens to the heart muscle? It dies. And we know that time is muscle, whether you're talking about the heart or the brain. And so the quicker we can get that heart muscle reperfused, the better. You remember that? And so this was kind of level 2 stuff. And there were 2 ways that we could open up a vessel. There's a Band-Aid approach for hospitals who do not have cath lab capabilities. And that is thrombolytics, or what we call clot buster medications. And what's the problem with clot buster
There's a
medications?
lot of contraindications.
There is a list, a mile long, of contraindications. And in the ER, we can't just go off of our brains because we've done it a bunch. There's literally a checklist that they must go down and go through.
You meet criteria.
Yes, you must meet certain criteria in order to receive thrombolytics because they are so dangerous. So I want to make sure I've said that enough. So thrombolytics help to dissolve a blood clot. Thrombolytics do nothing for plaque. You understand? So remember that when I talk about coronary artery disease, a big portion of coronary artery disease, and the reason people have coronary artery disease, is that atherosclerotic plaque. Y'all remember that? Mm-hmm. And remember that plaque is very rigid and hard, and it develops over time. And the problem is not necessarily the plaque as to why people have, it's not the only reason that people's vessels become completely occluded. The problem is when that plaque gets cracked because of stress or toxins that you're smoking or other reasons. And when it cracks, then the platelets in our blood go, hey, you see that crack over there? We better go get in it. And so then they all stick together and they pile up over that plaque, cracked plaque. And when they do that, they cause a clot that stops all the blood supply to that area of the heart. Okay? So that is why thrombolytics are a Band-Aid, because we can give them that if they meet criteria. And if we give them that up in Licksville, Mississippi, we have just taken care of the clot. They still have all that cracked plaque right there. So what's going to happen if they'll do it again. If we don't send them to a hospital like Spring Hill or somewhere close to them that has cath lab capabilities, because what can they do with the cath lab?
They go in and run a wire and get it out.
They can go in, run a wire, hopefully, and they can maneuver into the area and do what we call an angioplasty. They'll say I had the balloon, where they take the balloon in there and or there's some hospital cath labs that have really cool radio ablation, and they can go and they can chop up all that plaque and suck it out. And then they will put a stent. Why a stent?
Because it forces the vessel.
So it forces it because your vessels have memory. And they remember what position they were in. And so they'll go right back to the same position. So we put a stent to hold it open. What's the problem with stent? Well, it's a foreign body. You got to keep it clean, that's right. We got to keep it patent, because platelets are going to see that as foreign body.
Let's attack it.
And they'll go and just find their home and clot it all up, and then we're in the same what?
Same problem.
Same problem again.
Is that why drug-eluting stents are more placed than?
Yeah, no, well, yes and no. There are all kind of new stents on the market, and some stents have got medication infused into them to try to help prevent some of that. The cardiologists, the interventional cardiologists, they all have their favorites. They're all not evidence. There's not enough evidence yet. We've got a good bit of evidence, but there's new ones coming on the market every day. And so here's what I say when somebody in my family says, I'm going to get a stent. What kind of stent you get? And they go, what do you mean what kind? Whatever the kind the doctor puts in me. And so, anyway, so then if they're my family I like, then I'll go and start talking and tell me how many you've put in, what's the success rate, why this one instead of that one. So you got to learn to start having these conversations. And so do your own research. So I ask, what are you planning to put in? And then I say, what else is on the market? What are you comfortable with? So do you see how medicine is what you demand of it? And it's called medical practice for a reason. And so I'm just telling you this as a personal thing. They'll do anything you let them do to you. It's called medical practice. So before you decide or allow, you need to start researching on your own if it's you or your family. That's all I'm going to say. I will say this, that where I was going with this is there's two ways to open up these coronary arteries, right? There is go to the cath lab and do angioplasty and stent. But the problem with that is not every vessel can they navigate to, especially in women. And this is why women are more likely to die after they are hospitalized from an MI, is because men, their vessels are typically straighter and larger. Women, our vessels are typically smaller and more tortuous. So they're more difficult to navigate. And so there's not enough studies on women. Unfortunately, most of the studies are on men. But it's coming. We're coming. And so it unnerves me when I have a student or someone that, a friend of mine or family that says, I don't understand why they just can't go to the cath lab. Well, sometimes they'll take a patient to the cath lab and intend to do a cath procedure, but they cannot get the wire where it needs to be to do the angioplasty and the stent. So then it's a failed procedure, and then they're going to be, if they're a candidate, they're going to be scheduled to have an emergency bypass surgery, which we call cabbage. And so I just want you to understand that not everybody who has blocked coronary arteries can they go in and stent them, because that seems to be, a lot of misconceptions. So, all right. 2 ways to open up a blocked coronary artery. What are they? You tell me. Thrombolytics, which is a Band-Aid approach, but it will save their life and give them some perfusion until we can stabilize them and get them somewhere. And where's the other way?
Angioplasty.
And if that fails, where are they going? Open heart surgery. Okay. All right, very good. Y'all are doing really, really well. I'm very proud of that. So, MI is going to be one of your major focus areas. Do y'all remember the 2 types of MIs?
Non-STEMI and STEMI.
Very good. All right, we're going to get there. Heart failure. We're going to finish the story on heart failure. What's the worst part of left-sided heart failure you can have? What's that called?
Congestive heart failure.
That's old term. You don't even use that term anymore. They're not supposed to. Some doctors.
We still like it's CHF. It's CHF exacerbation. There we go.
Y'all are killing me. Okay. All right. When it's left-sided heart failure, the worst left-sided heart failure is called
Pulmonary edema.
high five to the
Hey,
to the girls in the back. Pulmonary edema. All right. So then, so I'm looking right here. Cardiomyopathy will be new for you. Cardiomyopathy. There's not a lot in your book. That's sad. You know why there's not a lot about cardiomyopathy in your book? What are we going to do for you if your heart muscle is diseased and it's damaged completely? All you can do is treat the heart failure and wait on a transplant. That's sad. So you're going to see what cardiomyopathy means and learn a little bit about the different types, and it's really sad. And then the last thing that's going to be new for you is valvular disorders. So we're going to learn a lot about valves, heart valves, and we're going to learn about the main heart valves. Do y'all listen? Y'all hear me? Which side works the hardest? The left side. So we're going to be talking about your mitral valve, which is on the left side, and your aortic valve, which is on the left side, and those are the valves that are replaced most commonly, and it makes sense because they do the most work, and they're under the most pressure. The other thing that you have already covered a little bit that we're going to make sure you got it is peripheral vascular disease. Remember, that's that big umbrella term. And when I'm talking about peripheral vascular disease, I'm talking about disease of the arteries going down to the legs. And that's called peripheral arterial disease, or disease of the veins coming back up from the heart. And that's called, I call it peripheral venous disease, but your book calls it venous insufficiency. And you'll have to skip over, I think, VTE, blood clots in the legs, to find it. Okay? Don't tell me it ain't in the book. Every semester I'll have a student that goes, Miss Cooper, that's not in the book. I'm like, turn on the page. Gotta go a few more pages. It's kind of funny. All right. But in the student's defense, it says like venous insufficiency, and it doesn't say peripheral venous disease. All right. Same thing though. All right. Under D, we're going to talk about the infectious inflammatory disorders of the heart, which is really fun. And we're going to be talking about all the itises. Call them the itises. So you remember the heart has a sac, and it's called the pericardial or the pericardial sac. So pericarditis is inflammation of that sac. And then the middle part of the heart is called the myocardium. And so myocarditis is inflammation of all the muscle cells in your heart, in that middle part. And then the last one that we see the most in the hospital, unfortunately, around here, is called endocarditis. And we see a whole lot of bacterial endocarditis. And unfortunately, a lot of that is from piercings, from drug abuse, dirty needles. When we see that in the beginning, I want you to talk to me about the blood flow of the heart. So it enters through the superior and inferior vena cava, right? Yes. And it enters on which side? Right. So when we see an echocardiogram that has vegetation on the tricuspid valve, what might that be telling us? IV drug abuse, because it's building up infection from the needles. And I'm going to talk to you about that when we get to there and explain what vegetation means and explain why that occurs from that. Now, there's other reasons that bacterial endocarditis can occur. I don't want you, every time you see that on a echo, go, drug abuser, because that's not the case. Actually, having a surgical procedure that was not done aseptically, we put that IV in and we weren't aseptic. Different procedures that were done and we broke sterile technique can cause some of that. And I'm going to talk to you about the patients who are most at risk for that. And some of you, does anybody in here have mitral valve prolapse? It's very common, and hopefully you know if you have it, because sometimes you don't even know you have it. My sister has it, and the whole thought process on it has changed. But if you have any valvular disease or disorder, problems with a heart valve, then your blood does not flow smoothly anymore through your heart. And if it doesn't, you're going to hear, if it's pretty significant, you're going to hear a murmur when you listen, if it's significant. Some that are small, you may not even notice. And if they are young, then a murmur's normal in some children according to their age. So again, these are missed a lot, but if the blood flow is abnormal through the heart because of a valve problem, and I just said that in general, didn't I, of a valve problem, then what you're going to have is irritation in the valves, in the inside of the heart where the blood's going through, kind of like a ditch. You know how if a ditch has water running through it, what happens to the dirt on the sides of the ditch? Erosion, right? Y'all know what I'm saying when I say erosion? Same thing's happening in the heart. So if you've got irritation in the heart, like, have y'all ever played ball and got a strawberry on your knee? Dear Lord. And that's irritating, isn't it? And you know what happens to that little strawberry on your knee? And then you get a scab over time, don't you? Well, I want you to kind of think about that from the erosion that's happening in the heart on the inside lining. And so then I want you to think about all the little platelets and all that stuff goes, oh, it's irritated. We gotta go help you. And then you injected with a dirty needle, and those little bacteria are like, I gotta find somewhere to live. And there's that little irritated strawberry looking scabby thing over there, and they go, ooh, look, we can vegetate right here. Okay? So that bacteria just sits there and lives there. And so anybody who has a valvular disorder or has irregular blood flow through their heart is at risk for bacterial endocarditis. So if they have any kind of oral or airway procedures, we have to make sure they take prophylactic antibiotics. For years, they said any invasive procedure. If you go to the dentist, you have to, if you have a valvular disorder. Even if you go to the dentist and have your teeth cleaned, they used to put you on antibiotics. But they don't do that anymore because we have developed superbugs over time. And they've done more research, and they found that antibiotics are needed when they have respiratory or oral invasive procedures. I will tell you, there's still some doctors out there that will order antibiotics for other invasive procedures based on the patient. Okay, but your book is going to tell you respiratory procedures and oral procedures. Does that make sense? And so that's what I'm holding you to. Your book is telling you the new science. All right?
If you have a valvular disorder.
Any valvular disorder. And so usually I'll have somebody in here and they'll go, yep, I can't even go have anything. I got to take him. So it's not as bad as it used to be. Thank God. Okay.
Oral procedure.
Okay, and that's in your book read, and I'm going to get to that, but I find if I tell you stuff in the beginning and then I hit it again when we cover it, you remember it better. Because some of you will start studying tonight, and if I say something and you read something, sometimes you'll remember it better. Yes. Is it time to again?
Well, no, I was gonna ask a question.
Oh, we can't get in trouble with it.
STEMI stands for ST elevation, right?
Yeah, we're going to get to that. STEMI is ST segment elevated MI, and N-STEMI is non-ST segment elevated MI. We're going to divide those down when we're covering MI, and we're going to really get into that. Okay? It's their turn to tease. They're really good. They've had a long time. Tell me what y'all know. We're almost ready to go for break. I know y'all are tired. So let's do a real quick review. What do you remember if I am in the ER and y'all don't go, what's the scoop? Everybody in her family dies. You better listen to her. I have modified all my stuff. I'm doing my best. And so don't freak out because I promise you I'm good. It's probably gas. Suffer with that.
Get a GI cocktail.
Yeah, that's all I need. But anyway, let's say it's not me. It's somebody we don't know because y'all, it's Jack. Jack, here's Jack. That's why I bring him in here. Because I don't want to hex none of us, including myself. All right, Jack's having chest pain. I love him. And he's come to the ER. So, all right, help me out. Chelsea works in the ER. What we going to do with him?
I mean, first we put him on a monitor and get an EKG
Okay.
as fast as possible.
Are we going to
We
get
can-
vital signs?
Putting him on the monitor is getting vital signs because
Okay, just checking.
it's our whole thing.
But
so.
not everybody knows that. I'm
Okay,
trying to
so
help.
we're getting blood pressure pulse ox, putting him on a 5 lead, and then we're also doing a 12 lead EKG.
Very good.
And then that's immediately read by a doctor. So, like our hospital, we have to get it within 10 minutes of them being registered.
That's any hospital if they're following ACLS guidelines.
We're STEMI certified, so
Uh-huh.
because of us being a STEMI hospital, we have to be under time, and if we're not, we get like knocked. But
So
so we
it's-
get it within 10 minutes of them being like put in our bed. If it shows like well, the doctor looks at it. If it shows certain things, then the doctor starts ordering. So normally, if it is a STEMI, they'll go ahead and do your like Mona, and we strip them down. If it's not a STEMI and they're still having chest pain and they have a like history of it, the doctor will order a nitro, usually nitro pays. Because they just like the nitro paste more than the pills because
They
it's
love
a waste
the
of pills. Like we have so many like random nitro bottles everywhere. It's like 30 pills inside of a bottle and they only use 3. And then almost if they have a history, even if they don't have a history and they're within the age frame, they're staying for the weekend.
Right.
Under
So,
odds.
thank you. Okay, that's what I needed. So let's talk about on a nasty morning and oh my. So when anybody's having chest pain, whether it's they're coming in the ER or you've been caring for them at the hospital, the first thing we got to make sure of, if this person is coming up to the station telling you they're having chest pain, first thing you need to do is get them in a wheelchair and get them back to their what? Room and get them where? In the bed. You can make them semi-Fowlers is fine, where they can breathe and comfortable. Well, why do we want to make them rest?
To calm the heart rate down.
Because it decreases the demand on the heart. Because if the person's up walking around, the other thing they're going to be is frightened. If they're having this chest pain and it's bothering them a lot, their sympathetic nervous system is going to be extremely stimulated. They're hurting.
Not only
And-
that, you got 17 people in a tiny room coming at you with a whole bunch of hands.
Right. In the ER especially. But on the floor it may be a little bit different. And so I always say, oh my. So we got to get the vital sign machine. So I'm going to grab it and go get the vital sign machine. Let's do a set of vital signs. And then what do we need to be asking about the pain?
Where's it at? How's it feel? How long has it been there?
And what do you remember about the duration?
Sudden onset within 30 minutes.
Okay, so if it's angina, it's typically less than
15.
and if it's an MI, it's greater than
30.
So you're remembering some of this stuff. So the other stuff that I have to make sure you remember, hint, hint, is how women present differently and how older adults, I'm talking elderly,
They present crazy.
oh yeah, oh yeah. And even diabetics present differently, and women and diabetics scare the ancient double hockey sticks out of me, and old people.
Elderly women.
And and because they are so atypical. A diabetic, remember how they have diabetic neuropathy in their feet and they don't even feel stuff they're stepping on? You're like, dude, that's a nail right there. You know, you're like, it's in your foot. And they're like, really? You're like, yeah. And so they can literally be having a STEMI. And they're sitting there going, I'm like, are you having any pain?
I don't feel good. That's
I
all
don't
it is.
feel good. I've just really been so weak. I got this weird pressure, and I can't tell. It's just really deep. It might even be my back, and I'm thinking, like, well, you got the big one, sister. Like, I just can't act like I'm upset about it, but oh my God. And because those are the ones that will fool you. And, you know, you're not excited at all. They look kind of bad, but you're like, I don't know what they look like normally. So, you know, and then you realize you got a OSHIT moment,
Yeah.
but you can't say that. So you say, oh my. And so what does that patient need immediately? Well, we got to get a set of vital signs. We got to get a stat 12 lead. We've got to get them monitored. We got to make sure that they have an IV. Because if they're going to try to die on us, we got to be ready to roll. And so that's the oh my part. Oxygen, we're going to put oxygen on them. We're going to make sure they're monitored and they have a stat 12 lead. And we're going to make sure they have an IV. And then we can start with the MONA in the right order of on a nasty morning is how I remember it. But oxygen, aspirin, make sure they're not allergic. And if they say it burns their stomach, say chew baby chew. And remember aspirin helps to do what to platelets? All right. Okay, so they need the aspirin. And then we're going to give them nitro. And if it was angina, then that would have helped. That would have helped, hopefully. But if it continues on like an MI pain does, they're going to need morphine or an opioid because we got to make sure they're not allergic to morphine because there are many people who are. So we're going to give them an opioid, morphine, we start with. And hopefully that will help. But there are many patients who have a heart attack or an MI and morphine don't touch it. All right? It's unrelenting pain. And the only thing that's going to help them sometimes is get their rear end. And when you see an ER nurse that has the personality of my husband, who don't get startled over nothing, there could be a dead body laying there with a head off, and he'd be like, oh, look. You know, and I'm like, God.
That's the only thing that scares me.
And so, anyway, when you see that nurse running down the hall almost with the stretcher, you know, oh, they got a stimmy. Because there's a couple of nurses that I know that I've worked with for 100 years that don't get excited over nothing. And if they walk faster than this, I'm real concerned. And so, and they're ER nurses. And so, look up on that stretcher. If that patient is very pale, I bet you they're having a stimmy. Look on their monitor, and you'll see them tombstoning almost heading to the cath lab. So you'll never watch people. You'll be people watcher like me. I'll laugh because one of the nurses I'm talking about, I was at the north end of Singing River's ground floor, and I saw him coming. And I went, oh, he got a stimmy. He needs this elevator. So I sat there and held the elevator. He goes, how did you know? I was like, you were moving a little too fast for my, I could tell. But anyway, why is he moving fast? Because time is heart muscle. Because if we can get in and get that area opened up quickly, then a lot of the muscle that is around the primary lesion can get blood flow and is not completely dead yet, and it will be wonderful. The problem is people wait at home for too long, a lot of times over 2 hours before they present to us. And if that's the case, a lot of times they'll die at home, and let me tell you why. If the pain is ignored, and when that heart muscle dies, it can no longer conduct electricity like it is supposed to. And once the heart muscle starts becoming irritated, because number one, it's hypoxic, and it starts leaking out. The most common, and this is something you need to remember, the most common complication following an MI that's going to kill them is dysrhythmias. Their muscle that is damaged is no longer able to conduct electricity like it's supposed to. It becomes irritated, and they will have those life-threatening dysrhythmias that will kill them before they get to the hospital. Most commonly, you'll see ventricular fibrillation if you're lucky enough to see it. And that is why they invented all the AEDs out in the public, because the most common dead rhythm that we can fix is V-fib, but we have to fix it within a couple of minutes. We have to shock it within a couple of minutes. Because if you don't shock V-fib in a couple of minutes, it goes right to asystole. And asystole is real dead. That's a flat line. There's nothing to work with. There's no electrical activity. All right, 10 minutes. You got 10 minutes